suffer from other dysfunction such as dysarthria. It's a kind of aphasia, but the problem is with the weaknesses of the muscles involved in speech production. With the muscle weakness may also cause dysarthria. This muscle weakness differentiates the dysarthria from aphasia. Aphasia is from brain damage, but here the patient has muscle weakness associated with speech production, named dysarthria. But they also suffer from, may also suffer from emotional ability. You are treating the patient seriously, but they suddenly begin to cry. They suddenly laugh, you know. This is named emotional lability. Is observed in patients with right hemispheric infarct or stroke. Therefore, if treating the patient with a stroke, if they started crying, started laughing, it's a kind of emotional level. They cannot control their emotions. Name emotional lability. Observed in left is observed in patients with left hemiplegia but right hemisphere.
In this situation, when the patient cry or laugh,
Yeah.
how you react in this situation?
Just asking to calm, to relax, and then when you feel they are relaxed and can control their emotion, you continue your treatment. You cannot do anything. Just you need to talk to him, to be relaxed, to control their emotion, breathe deeply, or for relaxation. After controlling their emotion, you can continue your treatment. But real is a problem, emotionally. They cannot continue treatment, they cannot cooperate after such emotions with physiotherapists. Therefore, you need to talk to him, to her, to control their emotions, to get relaxed. All right? But after stroke, their reflexes observed during the infancy, during the childhood, again reappears. These are the low-level reflexes integrated in spinal cord level, in brain stem level. All right, they are named primary reflexes. Spinal reflexes are flexor retrieval, cross extension, starter, and grasp. These reflexes may appear after a stroke. These reflexes usually are observed during the evolution of central nervous system in children when they grow. With maturation of CNS, central nervous system, these low-level reflexes are controlled or inhibited and integrated. But they may be seen after stroke. For example, grasp reflex may be appear after a stroke. Plantar reflex, grasp reflex may be observed after a stroke. Brain reflexes are brain stem reflexes are symmetrical tonic neck reflex, asymmetrical tonic neck reflex, and tonic ramp reflex, and finally tonic top reflex. observed after stroke is asymmetrical tonic neck reflex. With rotation of the head, the distribution of muscle tonus is changed. For example, when turning the head towards the affected side, extensor tonus is increased on the face side, but on the skull side, the flexor tonus is increased, and you see such posture. All right, but with rotation of the head towards the south side, the flexion tonus is increased on the affected side, but the extensor tonus on the intact side. With tonic time reflex, the stimulus is the posture of the patients. In supine position, the extensor tonus is increased. What with prone position, the flexor tonus is increased. Therefore, when assessing and treating the patients with stroke, we need to consider these reflex may work. For example, in supine position, with the legs in extension, extensor tonus of the lower extremity of the affected side will be exaggerated and will be affected by these brain stem reflex. It's a primary level reflex observed during the evolution of the stimulus during the infancy and the children. With tonic time reflex, when the involved upper extremity is elevated above the horizontal like that, the thumb extension may appear and facilitated with forearm supination. This reflex may be used, for example, when applying Brownstone approach for treating patients with a stroke. This reflex may be used for facilitating thumb extension. Elevating the affected upper extremity produces the extension of the thumb reflexively. Yeah, this figure is showing the thumb tonic thumb reflex. Elevation of the upper extremity, extension of thumb produced reflexively. But there are associated reactions in patients with the individual. Any difficult task, any new motor performance may trigger the associated reactions. Therefore, associated reactions are automatic involuntary movements that occur as a result of active or resisted movement in another part of the body, particularly on the intact side. The common associated reactions are Sotos phenomenon, Raynistes phenomenon, and homolateral limb synchynesis. What are these reflexes? Here you see that the Raynistes phenomenon. In supine position, when giving resistance to hip abduction and abduction, these movements will be produced on the affected side reflexively. When you give resistance to abduction, you will observe the abduction of the hip on the affected side. And when you give resistance to the abductors on the intact side, you will observe the reflexive hip abduction on the affected side. All right, as you see here. And this one, figure is showing the sockets again with elevation of the affected upper extremity, extension and abduction of the fingers will be apparent, but they are reflexively apparent, they are not voluntarily movements. And with the HLS or homolateral limb kinesis, when you, for example, on the affected side, when you flex, when you bend, for example, elbow, the same flexion movement will be produced in the lower extremity on the affected side. Therefore, any movement of the upper limb, for example, flexion or extension, especially the flexion movement, will produce the flexion of the lower extremity on the same side, on the affected side. Deep tendon reflexes may also be tested by physiotherapists, by neurologists, especially the neurologists use deep tendon reflexes to test the hyperexcitability alpha motor neuron, to test the presence or absence of the spasticity. Usually the tendon of these muscles are tested: biceps, brachioradialis, triceps, quadriceps, and gastrocnemius severus. Using the finger or reflex hammer can be used to tap the tendon to assess the reaction and score. We use this scale to score the deep tendon reflex. 0 means no response when tapping the tendon. 1 means minimum response observed with tapping the tendon. 2 equals to normal response. With spasticity, we observe really scores 3 and 4. 3 means hyperactive response, and 4 means close. Here you observe tapping, striking the triceps tendon. Here brachioradialis, and here you see tapping the patellar tendon for assessing DTR. You can also test your DTR of the patellar when sitting on the chair. But the stroke especially are associated with complication, especially if they don't receive the physiotherapy and rehabilitation. Abnormal posturing and positioning, shoulder pain and subluxation, RST, especially when the limbs, upper limbs especially, are not actively moved against the gravity. Trauma and fall is common, really, traumophlebitis, pain in muscles and joints, incontinence, psychological problems, or among the complications observed in people with a stroke. All right, do you know what symptoms can predict the poor or good prognosis for the patients? We consider all these symptoms: incontinence, aphasia, shoulder pain, shoulder subluxation, muscle pain, joint pain, behavioral problem. Which factors are among the factors that predict the recovery in people with a stroke?
The behavioral one.
Behavioral.
Yeah.
Which ones especially are predicting bad prognosis, poor prognosis for people with a stroke? Emotional, behavioral.
Actually, all of them.
No other idea?
Well, he
محیط environment.
All of them are important, but I
All
think
are important, but
the most
which ones
emotional.
predicting poor recovery, bad
Physical.
outcome? Which ones? Not emotion, not environment, not behavioral changes.
Physical one, that's the physical one, that there's
Pain? Pain?
No. Which one?
The lifestyle? The lifestyle?
No. First, aphasia. They cannot speak. They cannot communicate with others. And the other one? Existence of aphasia is a bad factor for recovery.
Ataxia. Ataxia.
No. Ataxia is, of course, really bad symptom, but it is not a predictor. First, aphasia. Second, second, second.
The emotions.
Aliana. Which one? I sent all the slides to Aliana with the files of the Martin Kessler book and Bobat book, alright? And I sent Ali one question about the Tardieu scale, modified Tardieu scale, to solve. Create the group Aliana, alright? Create a group with all students in this group. Alright, the second factor is incontinence. These two factors are important. The existence of these two factors in patients with this sort is a bad predictor. The existence of these two factors predicts bad recovery, poor recovery. But what are the mechanisms of recovery after stroke? We observe after physiotherapy, after treatment, they can walk, they can move their arms, they can speak, they can communicate with others, or although not normal, but they can talk, they can walk, they can function in the society, they can take responsibilities for their jobs. They return to the society to perform their social roles or perform their ideal activities of their day. What are the mechanisms for recovery? What do you think? No idea?
What do you mean by mechanisms?
Reasons for recovery. There are various mechanisms suggested, recommended for possible mechanisms for recovery observed after stroke. From von Monaco's Aske's theory, nervation supersensitivity, vicarious function, functional reorganization, neural sprouting, and behavioral strategy change. All these are suggested for possible mechanisms of recovery after stroke.
I don't understand the idea of these mechanisms.
Do you know what the term today we use for recovery observed after stroke and for all other upper motor neuron syndrome conditions?
I don't understand the idea of the mechanisms. You mean we use it for recovery or it is prediction for recovery? I don't understand.
You treat a patient with a stroke,
Yeah.
all right, they recover. They ask you what happened, how did you recover me? Huh?
So we use one of these theories.
There are possible mechanisms suggested for recovery.
So according to this theory, we make a plan, a treatment plan, and then the patient recover or what?
What's the reason for the effectiveness of your techniques? They're asking you, the patients, their family, even the physicians ask you, what happened with your techniques that the patients recover? You may use one of these to describe what happened that they recover. Do you know what term we use today for recovery occurring after upper motor neuron syndrome conditions such as a stroke? Do you know the term? No? All of these may be described under the term of neuroplasticity. Neuroplasticity. You can say neuroplasticity occurs. The CNS, the brain is not rigid, can be recovered, can be changed. You apply the techniques to change the brain of the patients. Neuroplasticity term refers to the changes occurring with any intervention that people with a stroke receive. And the other patients with other conditions under the upper motor neuron syndrome, such as multiple sclerosis, spinal cord injury, Parkinson's disease. If they recover, the major mechanisms in neuroplasticity, because brain, such as like other tissues in the body, can be changed, can be adapted. You can shape the brain of the patients. Human also shape the brains of the healthy subjects, because the brain is adaptable, it can be changed. That's why some people say we wash the brain of the people. Yeah? This refers to neuroplasticity. Therefore, CNS is not rigid, brain is not rigid, can be changed. But the possible mechanisms suggested for recovery after stroke are these mechanisms. What is for Monaco's diastasis theory? What is it? In recovery, during the early period after stroke, may be explained by this theory. Another name for Monaco's diastasis is functional shock. After a stroke, the brain and body is in shock condition. Even intact neurons are not working. That's why it's named functional shock. And this term is used to indicate that even the normal neurons are not working after stroke in initial early period after stroke. And diastasis refers to decreased activity of surviving neurons after damage to other neurons. During the early period after stroke, for example, during the 2 weeks after stroke, any recovery may be explained by this mechanism. We don't assess, we don't predict the recovery during, for example, 2 weeks post-stroke, because due to edema, swelling, even surviving neurons are not working. After 2 weeks, for example, the patient with stroke may stand up and walk and complete recovery. Alright? Therefore, this recovery may be explained by this mechanism. Functional shock theory or von Monaco's diastasis theory. Therefore, any recovery observed during the early period after stroke may be explained using this theory. One of the questions for the exam was about this mechanism. We asked how you can describe the recovery observed during the early period after stroke. And the correct answer was the von Monaco's theory. Therefore, when you assess a patient with a stroke during the acute phase of the stroke, you need to wait at least for 2 weeks to see whether after decreasing the swelling and edema, what improvements you observe in your patients. Therefore, some recovery may happen spontaneously due to decreasing edema and swelling. As you see here, when edema decreases, improvements appear and occur. Therefore, according to von Monaco's diastasis, the changes are reversible and impairments are temporarily occurring. Therefore, this theory can be used to describe any recovery of function in the early period after a lesion such as a stroke. Another possible mechanism is denervation supersensitivity. Therefore, according to this theory, the denervated neuron, denervated area of the brain heighten the postsynaptic responsiveness of the neurons to neurotransmitter substances. Therefore, they are sensitive. They become increasingly sensitive to the remaining afferent signals and input. In this way, they may help the patients recover to take over the responsibility of the dead neurons. Another theory is redundancy theory or equipotentiality theory. According to this theory, several parts of the CNS may mediate the same motor function. For example, sensory neurons even perform motor activities when necessary. Therefore, remaining intact tissue continue to mediate the same function, even sensory neurons may mediate motor functions. Therefore, the severity of the stroke is important. All right? According to this theory, other areas of the brain may take the responsibility of the dead neurons. Therefore, the same function may be mediated by other areas of the brain that is not usually their responsibility, is not their functions. Therefore, based on this theory, effect of lesion depend more on the amount of tissue spared than on the location of the lesion. Reason, you asked about the area. I described that there is a network. Even all our neurons in other areas may mediate the same function. Even sensory neuron, this study, physiological study showed that even sensory neuron may mediate the motor functions to help to perform, to actively contract the muscle, perform a motor function. Therefore, effect of lesion is not dependent on the location of the lesion, but the amount of tissue escape after stroke. Vicarious function. The CNS, the brain has billions of neurons. According to vicarious function, most of the neurons are in sleepy conditions. After a lesion to the CNS, to the brain, such as a stroke, these latent functions, latent neurons would become over. The system asks the sleepy neuron to wake up to help. We have billions of neurons. And vicarious function refers to this capacity of the brain that have a latent capacity. They have billions of neurons that may wake up to help to take the responsibility of the lesion neuron. Therefore, after the lesion, these neurons may work to help, may become over, to wake up, to help, to mediate the lost function. And another mechanism is functional reorganization. I'm asking you one question. What other important mechanism is when you're treating the patient? What do you expect to observe true recovery? If you want to observe true recovery, if you want to create a true recovery with your treatment, what mechanism must work? What's that mechanism?
Your gateway. Your gateway.
What?
Gateway.
No. What mechanism must work to observe true recovery? You have need for a split game on the computer. Yeah. When there's a crash and when the car is destroyed, you press the button, you restore the car, all right, such that there was no damage to the car, all right. What mechanism must work to have such a recovery? To press the button to observe the true recovery, such that there was no stroke, there was no dead neuron. What do you think? What's it? Think about this. But functional reorganization occurs. According to this theory, neural system may change its function qualitatively. Another pathway, another neural pathway may take over the control of some motor behavior, not usually ordinarily part of its responsibility. Therefore, Again, according to functional reorganization, multiple brain areas may be activated during the same task to help to perform the function. Did you find the answer?
We must working on regulatory system.
Alright, this mechanism may help you to find the answer. Pay attention, please. This mechanism may help you to find the answer that what mechanism may cause true recovery, restoring the function completely. Alright. One other mechanism suggested is neural sprouting. Therefore, reorganization may occur, which refers to new growth in damaged neurons. And the newly generated
Neurogenesis?
axons may re-innervate the innervated areas. Or you may observe collateral sprouting that, according to collateral sprouting mechanism, there is new growth in undamaged neurons adjacent to the destroyed or damaged neural tissue, giving a branch to the area affected to take over the responsibility of the neurons. Did you find the answer? Neural sprouting may be in the form of reorganization. There is a new growth in the affected area, or maybe in the form of collateral sprouting, giving collateral branches to the affected area to take over the responsibility of those affected neurons. The scientists, the clinicians, are seeking a way to have true recovery, and true recovery may occur with neurogenesis, to survive the dead neuron,
So what's
or
the difference?
produce new neurons instead of dead neurons. All these mechanisms are not associated with true recovery. I may accept as a photographer to take the responsibility of the person responsible for photography, but I'm not expert. Those neurons helping sensory neurons, for example, may act as a motor neuron to take over the responsibility of the dead neurons, but the quality is not the same. I maybe photograph, alright, but my quality is not equal to the quality of the main photographer of the university. And here is also like that. We looking for a neurogenesis to produce or to survive the dead neuron. That's why you don't observe complete recovery, true recovery with medical treatments, with physiotherapy and rehabilitation treatments. And the improvements are relative ones.
So, Doctor, what's the difference between neurogenesis and neuroplasticity?
Neuroplasticity is an umbrella term for any changes occurring with any technique. All these can be categorized, can be described on the term of neuroplasticity. But neurogenesis is producing the neuron, new neurons, or surviving the dead neurons to take their responsibility.
Doctor, how produce this neurogenesis?
Neurogenesis is producing neuron,
How?
new neurons. We don't know how. What we are, scientists are trying to find a way to produce new neurons or to survive the dead neurons. It's a real challenge. That's why we don't observe true recovery, complete recovery in upper motor neuron diseases, in neurological conditions. And scientists are working to reach to this ultimate goal and aim in producing new neurons or to survive the dead neurons. What do you think about this mechanism? It's a compensatory mechanism. When all other mechanisms are not working, I compensate the dysfunction with using other muscle groups. Using other muscle groups to perform the function is described under the mechanism of behavioral strategy change. You may also normally use other muscle groups to perform your function. You have many books carrying with you, alright, and you want to open the door. You cannot use your hands to open the door. Therefore, you use your leg to open the door. It's the behavioral strategy. Using other muscle groups to perform your function. In this example, using your legs to open the door, for example. Not using your hand, because you are carrying many books, for example, many other objects that you cannot use your hands to open the door. Therefore, you use your legs. This is a behavioral strategy. This is not true recovery. What do you say about this? It's an important mechanism. That's the mechanism that cause we use TDCS or TMS for stimulating the brain. What mechanism this figure is showing? what mechanism? What mechanism is showing? What is it's showing the brain after onset of stroke in acute phase. What you see here? This hemisphere is lesion. Here is the location of the lesion. What do you see here?
Indications?
The intact hemisphere is working instead of the lesion hemisphere. It's taking responsibility, it's taking over the responsibility of the lesion hemisphere. All responsibilities are performed by the intact hemisphere. M1, premotor and supplemental motor areas are hyperactivated. That's why it's large and expanded area on the intact side. After 6 months, what happened? What happened after 6 months? Stand up, very stand up. What happened here after 6 months?
The area is decreased.
The brain is recovering. Step by step is accepting its responsibility, taking over some responsibilities to perform the function. That's why here you see these areas are reducing their help to the lesion area. Here is larger. Now some responsibilities are given to the lesion area to perform. And after 1 year, with 2 recovery, what happened? The responsibility is completely given to the lesion area because it is recovered. According to this theory, when this doesn't occur and all responsibility is taken over by the intact area, the scientists and clinicians believe that that's the barrier for true recovery. Therefore, try to decrease the activity of the intact hemisphere using the TDCS or TMS, using inhibitory parameters to decrease the activity of the intact hemisphere, to give the responsibility again to the lesion area. Therefore, try to stimulate the lesion brain to increase the activity of to increase the responsibility of the lesion brain to take over its responsibility, to take over its function. All right? This is the mechanism TNS and TDCS works in treating patients with a stroke. Alright? What factors are effective for the recovery of patients with a stroke? Age, younger patients have good prognosis. Gender, treating women is really difficult. Alright. The characteristics of the lesion size, momentum and pattern, and finally experimental factors, Zainab said, environment, are important factors. Environmental exposure or training are important for recovery. What this factor is saying to us? Here, this emphasizes the role of environment and training. Enriched environment is important for recovery. Patients living in an enriched environment have good chance for recovery compared to the poor people living in a poor environment. As you see here, is an experimental. This theory is performed with laboratory animals. As you see, here is a standard poor environment, but here is an enriched environment. Providing an enriched environment for recovery is important. As you see here, there are sensory bombardment of the brain when the animals, when the patients live in an enriched environment under the influences of various sensory signals, smartphones, laptops, all provide sensory signals that cause to have enriched brain and developing expansion of the brain areas. Therefore, as you see, with enriched environment, there are positive effects on the neurons. But with the poor or standard environment, there are no changes in the brain. Therefore, it's important to provide an enriched environment for the patients to work, to be actively involved. For example, asking the patient to use their smartphones to play with the applications.
So how that's having good? By enriching the environment, the neuroplasticity is good. Why?
Why? I said why. Because there are bombardments, sensory bombardments of the brain. When you receive sensory signals continuously and richly, there are conditions for growing of the neurons. The communication among the neurons are increased. For providing such a network to communicate with the other neurons when there are bombardments, sensory bombardments, there are new growth of the neurons, dendrites, axons, and this helps to communicate, to expand the communication among the neurons. That's why they can receive many sensory signals. In this way, can help the brain to recover, to experience true recovery. As you say, it's from a study reported when testing this hypothesis whether enriching the environment can affect, can influence the brain, they found that yes, there is dendritic growth, the communication among the neurons increase, there are new growths, and these occurrences help the patient to recover effectively. All right, are there any questions? We reviewed the neurology basis of the stroke. Now you want to treat a patient with a stroke. What strategy we use in physiotherapy to help to recover the patients with a stroke? All right, any question? Is this area, are there, is the class is enriched? What do you think is enriched with sensory signals? What do you think about the university environment, environment of schools for children, high schools? What do you think? Are their environments enriched?
No. In Iraq?
No. As a whole, I'm asking all over the world. Are their classes enriched? Do we have enriched environment in classes all over the world? In universities, high schools, schools, primary schools? What do you think? Our brain is changing?
What do you mean by orange?
I'm gonna emphasize the role of environment for learning and influencing the brain. I'm asking as a model, is this class, for example, is an enriched environment for our brain to have neuroplasticity? Could be. Do we have such an environment here now?
No.
No, this area.
Not area, this class. Our brain are not changing. I'm saying such an environment is an enriched environment. Why? The universities, primary schools, high schools, any other areas with learning is an enriched environment because our brain all are changing constantly. And neuroplasticity occurs in our brains because we are learning, and learning needs an enriched environment. And all universities, schools, primary schools, high schools are enriched environment, provide enriched environments learning occurs. Therefore, if you get MRI from our brain, for example, this morning, if we have MRI of brain, and again, now to have MRI of the brain, you will find there are changes. Our brain hypertrophy and areas of the brain expanded. Undoubtedly. Therefore, neuroplasticity occurs. Alright? Therefore, areas of the brain, especially associated with learning, expanded. And now you have expanded brain. Your brain areas expanded. That's why educated people with this stroke have good prognosis due to the expanded brain obtained during the study, during the education, during the studying the books, booklets and like that. Therefore, providing a learning environment for the patients will help to recover quickly. All right. As a result, therefore, we have enriched environment right now, and all of us experience neuroplasticity. You can test this hypothesis. Ask some students, for example, from primary school, high school, or university students. All right. Get an MRI when started their study, for example, and get another one after the completion of the term. All right. You will find the differences. Clearly, you can find the differences between the two MRI scans.
That's because getting a new information, not because there is a question. Because maybe the students study in standard environment.
All these are categorized under the environment. Getting information is a kind of enriched environment. Those animals obtain new information when they are in an enriched environment because they obtain various signals, sensory signals that help to expand their brain. When you are studying, your brain is experiencing neuroplasticity. All right. Therefore, all of you experience neuroplasticity right now. All right, in physiotherapy, there are two strategies. Conventional strategies are based on a standard exercise treatment. And there are scientific advanced techniques used along with conventional exercise treatment. All right. There are conventional interventions, primarily, majorly based on exercise therapy, such as what? What strategies? You already know them. PNF, yeah? You have passed the PNF? Yeah. PNF is a strategy, conventional strategy. that can be used for treating various conditions such as a stroke. These conventional strategies are such as PNF, Bobat approach, Braunstrom approach, Rudd approach, and like that, or MRP approach. These are conventional exercise therapy approaches for treating patients with neurological conditions, pediatric and adult patients with a neurological condition. All these approaches can be used to treat these neurological conditions. And there are advanced techniques such as virtual reality interventions, robotics, using smartphones or mobile as a tool for virtual reality interventions. Recently, I published an editorial on the use of mobile and smartphones as a tool for virtual reality treatment of patients with a stroke, especially in epidemics such as coronavirus epidemics, such as in war conditions. We can use smartphones, mobile, to continue the treatment of patients with neurological conditions, and particularly stroke patients. There are advanced techniques. Functional electrical stimulation, FES, is an advanced technique that can be used along with conventional exercise therapy techniques. Thermal stimulation, mirror therapy. These are advanced techniques used for treating patients with a stroke or other neurological conditions. You want to raise that as well? Is the time over? Yes? Yeah?
Yes.
Okay, just one step. Let me explain this one. One commonly used approach for treating a stroke and other neurological conditions in children with cerebral palsy, in adults with a stroke, in adults with MS, is the NDT approach or Bobat approach. This approach is presented by Bobat and his husband, Dr. Bobat. He's a pediatric neurologist. These two, especially Bobat, presented and provided the NDT approach now in the United States, and Bobat approach all over the world. These two clinicians and scientists provided the Bobat approach in 1950s, for 60 years ago. But this approach has sound, strong scientific basis that's again now is commonly used all over the world. Even Carr and Shepherd, both Australian scientists and physiotherapists, stated that although their approach is based on new motor control theories and this functional task-oriented based approach, but it's not commonly used all over the world. But Bobat approach is commonly used approach. For example, if you want to go to Europe to work as a physical therapist, they will ask you, do you have certification about the Bobat approach? Are you familiar with this approach? Did you pass the approach, NDT approach, during the study of BSc of physiotherapy? Many physiotherapists come to our workshop to get this certification of Bobat's approach. If they want to, especially when they want to go, especially they state that want to go to, for example, Germany, Europe, and other countries, they ask them to provide the certification of familiarity with this approach. Therefore, it's a common use approach presented and introduced by BOVATs, especially BOVAT that developed and described the approach to be used in children with cerebral palsy and in adults with stroke and in other conditions. Therefore, rest for 15 minutes and then again back to continuity.